I really look forward to presenting our next presenter, Dr. Joyce Fogel, a professor in the Department of Geriatrics and Palliative Care at the Icahn School of Medicine at Mount Sinai. Dr. Fogel has been in clinical practice in the urban areas of New York City for over 40 years. She maintains an outpatient practice of the Martha Stewart Center for Living at Union Square, which is a comprehensive geriatric program providing care to healthy older adults as well as ongoing care and management of chronic illness in the frail older adult. She teaches medical students, residents, and fellows and other professionals, and has also been really involved in community outreach, engagement, and education. And she's spearheaded numerous efforts to allow older adults to be more educated consumers of healthcare. She's also one of our esteemed winners of a Clinician of the Year award from the American Geriatric Society, and really look forward to Dr. Fogel taking us through delirium, both the diagnosis as well as management. Dr. Fogel, thank you for being here today.
Thank you so much. I'm delighted to be chatting with you about delirium this morning, and I hope at the end of this becomes a little bit more of a conversation. Some of you may have heard me speak on this topic in the past, and I've added some new things for 2025. And if it's the first time, then I hope you get a lot out of it as we move forward. Oh, there it goes. I have no disclosures. The objectives today are really to develop an understanding of the epidemiology of delirium, identify clinical features, risk factors, understand the relationship between dementia and delirium, and talk about both the prevention of delirium and how do we manage it, both talking about pharmacologic and non-pharmacologic approaches. This is a little slow. There we go. Yeah, so there we go. Sorry about that. The screen is being a little slow. So I'm going to tell you about a patient of mine, Carol, actually, someone I took care of just a few months ago. She's 82 years old. She has hypertension, depression, mild cognitive impairment. She had severe AS and was pending a TAVR, independent, and lived alone, although her son checked in on her and helped her, taking sertraline, hydrochlorothiazide, and benazepril. Since COVID, she was drinking 2 to 3 glasses of wine a night. It wasn't initially quite obvious to us that she was doing this. Her son calls that he thought mom was acting a little different. She was a little more confused, maybe a little more depressed. He's not sure whether it was important or not. And we set up an appointment for her to come into the office the next day. The following day, he calls. She has nausea and vomiting, unable to keep anything down. She's referred to the ED, and she's diagnosed with acute cholecystitis. Post-stenting, she has even more increasing confusion. There are times she's lethargic. She's become combative, and this is a woman who's never combative. Her son is really concerned about her functional decline and her ability to return home. We'll come back to Carol. So what is delirium? Delirium is an acute disorder of attention and global cognition. It has been called many things in the past: acute confusional state, organic brain syndrome, toxic or metabolic encephalopathy, my very favorite, subacute befuddlement. It has been noted in the Greeks dating back more than 2,500 years. So it's not a new phenomenon. Think of delirium as acute brain failure the way we think about acute renal failure. You might think about the encephalopathy as being the pathophysiology of the brain, and the delirium being what we see at the bedside. And we're going to talk more about what's at the bedside. When I gave this talk in person, when this course was in person and it was at Baruch, after I gave the talk, one of the participants came out and brought me to the hall and showed me this picture. And this is a picture entitled Delirium. So in Latin, the word lyra means the ridge left by plowing. And deliria was someone who couldn't make a straight ridge when they were plowing. So thus it came to mean a crazy or disoriented person. So I thought that was really kind of fun of where the word came from. Delirium is a very common phenomenon. About in the United States hospitals today, 5 older adults become delirious every minute. That's a really striking statistic. More than 7 million hospitalized Americans have delirium each year. On an average, a third of patients over 70 who are admitted to a general medical floor have delirium. Half of these are delirious on admission. Carol, my patient, it's not that she developed it during hospitalization, it worsened. And these numbers are even more striking in mechanically ventilated patients, in ICU patients. Patients who are admitted to subacute rehab may be going there with persistent delirium. So it doesn't necessarily resolve, and we'll talk about that persistent delirium. It's not just an inpatient phenomenon, and I think that's I spend a lot of time in the outpatient setting, and we have patients all the time who present to us with delirium, and we have to sort out how sick are they, do they need to be hospitalized, what's going on. So it's not just an inpatient phenomenon. So what? Someone develops delirium. Well, delirium actually is a medical emergency. The consequences of it can be significant. Falls, incontinence, pressure ulcers, inability to take in oral, use of restraints, which just is going to make the delirium worse. Unable to make decisions for themselves about their care. Now, I like people to think about delirium in terms of the 5Ms, and I think that you probably heard about those 5Ms during the beginning parts of this course. And matters most, okay, people can't make decisions about their own care if they are delirious. It is a traumatic event. There was a study done of lived experience of patients who were delirious in the ICU, and they were interviewed afterwards, and they shared that they had shame, guilt, remorse, and fear. So they don't forget it. It's not like, oh, you won't remember what happened. There can be permanent cognitive and functional decline. It has 10 times the mortality of sepsis. That's 10 times the mortality of sepsis. Both hospital mortality, which can be depending on where the patients are and their other risk factors, can be up to 3/4. 1-year mortality can persist. So we're going to talk about who has more of that higher mortality risk longer term. It's also expensive, right? Hospital costs, it's estimated more than $11 billion a year. And it's not just the hospital costs, it's the post-hospital costs. What happens those patients going to rehab facilities or long-term care, recurrent emergency room visits, home care expenses, and something that we can't measure in dollars and cents, which is caregiver burden. Delirium really can have an impact on caregivers. This was a study done by IHI in Hartford Hospital, and it looked at hospital length of stay and cost of stay of patients with and without delirium. And you can see the length of stay increases, and the cost for the length of stay is more than 3 times those patients without delirium. As I mentioned, it's not necessarily a short-term phenomenon. We hope we can do things to intervene to have the cost be shorter, but this can be a long-term phenomenon with persistence related to pre-existing patient risk factors, and we'll talk about risk factors including age, underlying cognitive impairment, multiple comorbidities, use of restraints, and the severity of delirium. Persistent symptoms at discharge at 6 months can be up to 20% of individuals. And the more prolonged the delirium, the higher the risk for death, actually. Why does delirium happen? Well, good question. There's been a number of mechanisms proposed, and you can see that one of the most popular is the cholinergic hypothesis, reduced cholinergic inhibition, brain injury and neurotransmitter alterations, neuroinflammation, decrease in the blood-brain barrier, and toxins crossing the blood-brain barrier. So those red X's are places where, based on these hypotheses, where things have been tried to have delirium prevention. They haven't worked, and we'll talk about prevention and treatment a little later. I want to emphasize that delirium is a symptom and a syndrome. It is not the diagnosis, and it behooves us to look for what is the underlying diagnosis. And how do we do that? What are we looking for? So how does a delirious patient present? They can present either hyperactive or hypoactive, and about a quarter of delirium can be hypoactive. You may see a prodrome of patients who are confused, irritable, and then development of the core symptoms of alteration in consciousness, attention, cognition, and perception, maybe hallucinations, delusions, and the associated features of alteration in sleep-wake cycle, psychomotor retardation or excitation, affective symptoms, depression, crying, autonomic and neurophysiologic, tachycardia, sweating, blood pressure alterations. A study that was done that looked at, in Canada, 717 patients in a general medical service, and 315 developed delirium. That's actually a pretty high number. And they found that almost half developed delirium in the morning. There is this misperception that it is sundowning and that they develop at night. Well, not necessarily so. Almost half had behavioral manifestations, and a quarter were hypoactive. So that's important information to carry with us. Why do some patients develop delirium, or why do they develop delirium more easily? So it's this balance between predisposing factors or vulnerability and the insult. The higher your vulnerability, the less noxious insult is needed to precipitate delirium. And we're going to look at those. So what are those predisposing risk factors? So advanced age, underlying cognitive impairment or dementia, 5 times the risk. ADL and functional impairment, more than 4 times the risk. Multiple and severe comorbidities, 5.5 times the risk. History of alcohol abuse, more than 5 times the risk. I don't know why male gender has a higher risk. It's an interesting thought. And certainly sensory impairment, hearing and visual impairment. And what precipitates? So you have those patients with those vulnerabilities or underlying risk factors, and what's going to trigger them? So anything that you can possibly think of that can occur to an older adult can trigger them, whether it's the infection, the myocardial infarction, being admitted with pneumonia and hypoxia, pain, any of those things. And then the things we might not think of as commonly, fecal impaction, bereavement. I had a patient where this was actually what was going on. Environmental changes, being moved. The patient who's actually was taken on a plane to California and got really delirious because of the time change, right? COVID was a real precipitating factor for delirium, and we'll talk about why later on. And it was often missed because the patients were delirious. COVID wasn't really thought about. So I highlighted medication and restraints. I will keep saying to you, don't use restraints. Restraints will increase the risk of delirium. Medications. Any medication that's going to affect the brain can precipitate delirium. Anything that causes sedation or those drugs with anticholinergic side effects. I could spend an hour just talking about medication, but I don't have that time. But I will bring to your attention this great tool, which is the anticholinergic burden calculator. So you can load in the drugs that your patient is taking and find out what the anticholinergic burden is. So for fun, I put in oxybutynin and diphenhydramine. And there it is. My patient has 6, high risk. Your patient scored greater than 3 and is therefore at high risk of confusion, falls, and death. It's kind of scary. I've actually used this to try to get patients off drugs I don't think they should be on when they say, oh, but why? Why can't I take it? And when I show this to them, they think about it a little differently. We have to mention post-op delirium, or that again can be a talk in and of itself. So I am going to call your attention to Geriatric Care Online, the American Geriatric Society Clinical Practice Guidelines for Post-op Delirium. This is really an excellent, excellent document. And if you work with surgical patients, I suggest you look at it. So about a quarter of major non-cardiac surgery patients can develop delirium. It's higher in high-risk surgery. So cardiac and hip fracture surgery, it is even higher. Interestingly, the type or route of anesthesia doesn't matter. And you would think, oh, the patients maybe who got spinal anesthesia, less post-op delirium. It wasn't true in a number of studies. Just like anybody else who develops delirium, there's an increased risk of mortality, longer hospital stays, delayed functional recovery, and surgeons don't like this. So they're now paying attention to delirium and persistent cognitive dysfunction. Post-op delirium can occur at any point. It can occur 10 minutes after surgery to up to 7 days. What's also important to point out in post-op delirium is there are some additional factors that may occur intraoperatively or postoperatively that put the patient at risk. So fluid and electrolyte shifts, anemia, hypoxia. So all of those things, and pain, of course, may precipitate it. I put this mnemonic up here, and this is just for you. We've talked about a lot of these precipitating factors, and this is for you to use in your teaching where you're trying to get those students to think about the causes of delirium. So we have to talk about the 3Ds. Although I prefer now using the term neurocognitive impairment to dementia, we have to call it dementia for this purpose. Otherwise, I lose the concept of 3Ds. So there's a lot of overlap between depression, delirium, and dementia. And sometimes we have to really tease it out. So Carol, if you remember her, she did have some depression. Her son was wondering, was it her depression? Was it worsening cognitive impairment? And I'm thinking, is she delirious? So there's a lot of overlap, and it's our job to figure it out. And how do we do that? So this can help a little bit in looking at some of the differences between delirium and dementia. There's a lot of overlap, and it's hard sometimes to tease it out. But the most important things to think about is onset, acute versus gradual, course, fluctuating versus stepwise, the inability to concentrate acutely in delirium as opposed to dementia where it may vary, and the duration being short duration as opposed to dementia having a long duration. I said I would come back to COVID. So this was the cover or the lead article in Nature in 2020. The link between delirium and dementia. And they were talking about COVID patients who are confused, potentially having, excuse me, long-term cognitive impairment. So it was being seen then. So I mentioned delirium was often the presenting factor in older adults for COVID. And early on, it really wasn't being picked up, and especially in long-term care settings. So it being missed, there was more rapid spread. And it is still, I had a family member, an older family member this week have confusion and get admitted with delirium and COVID. So why are we missing it? And what's going on that we're missing it, and how can we really look at that a little bit better? Did I miss a slide here? Nope. Okay, sorry about that. We miss it for a lot of reasons, and I think my slides are shifted, but we're going to talk about that. We miss it for a lot of reasons, and there's barriers to recognition, which may be the confusion between delirium and dementia. It may be a poor conceptual understanding by staff of delirium, and a study done that looked at these barriers inquired with nurses and physicians if they thought the patient was delirious against a validated tool, and only a third was being picked up. The nurses did a better job, 50%, and the physicians only picked up 20%. And when I was looking for some new information about delirium, there I found in the literature that Mount Sinai, and I hadn't known this, just developed this AI model to improve delirium prediction. Well, that's pretty impressive. So they used the gold standard of the CAM, and I'm going to come back to the CAM, and they developed this AI machine learning model with the EMR to predict delirium. Before the use of this tool, on these floors where it was piloted, there was about a 7% documentation of delirium, and it went up to 17% using this model. But we can't just rely on that. We do have to think about clinical judgment. Clinical judgment is really important. The gold standard of assessing for confusion is the confusion assessment method developed by Sharon Inouye, who I think of as the mother of delirium, in 1990. And it is still what is used. It's been adapted for use in ICUs and ERs. It is acute change in mental status and fluctuating course, inattention, and either 3 or 4, disorganized thinking and altered level of consciousness. So that patient may have, as I mentioned before, hallucinations, delusions. Their thinking may be very disorganized. So this has an incredibly high sensitivity. But as I said, it does require some clinical judgment. And we just talked about barriers to recognition, so I'm going to pass that. Other things, though, that can be used is an ultra brief 2-item screener, the UB2. This is really simple. Tell me the day of the week. Tell me the months of the year backwards. Say December is your first month. So any healthcare provider on the unit can do it. And although less specific, only 64% specificity, it does have a 93% sensitivity. And this is a really easy tool to use. So I say we still have to use clinical judgment. We have this validated tool we can use. We have AI learning and use of the medical records, but we need, as clinicians, to get information. If you are suspecting delirium, if somebody screens positive, 1, assume reversibility. 2, confirm. What's the timeline? How long did it take to develop? Are there associated events? Sensory deprivation, someone lost their hearing aids, their glasses. Is there pain? Speak to families and caregivers. That ancillary information is so important. Right? You're seeing that patient at one point in time. Review notes and medication. I can't emphasize that enough. When Carol went to the emergency room, it wasn't documented that she had been drinking significantly. Nobody looked at the outpatient notes initially in the ER. So think about alcohol and substance abuse or substance use in older adults. You do a good exam, get your lab and blood work. I'm going to put in a word that people say, well, does everybody need CT, EEG, LP? The answer is no. You're going to guide ordering those tests based on what you see. You have a patient who had a head trauma, was confused, of course you're going to get a CT. You have a patient who has a fever and is confused and you have no other source of infection, you might want an LP. Family described something that was might have been a seizure at home, you might want an EEG, right? So let your clinical judgment guide what things you order. Risk assess that patient. Are there things that you need to pay attention to that might make the delirium worse or be impacted by the delirium? Language barriers, cultural issues, sensory barriers. They don't have their hearing aids, their glasses. Capacity. Can they sign consent for their procedures? Can they comply? Are they pulling out their IV or taking off their oxygen? Safety. Many years ago, my grandmother had a hip fracture. She developed post-op delirium, but she was quiet and nobody really paid attention. And she climbed over the side rails and refractured at the operative site. Boy, was that surgeon upset. So look and assess your patients. Take the time to assess them. How do we manage delirium? So as I mentioned, we have to look for the underlying disease and treat that process. Avoid other causes of delirium. So sedation, restraints, turning lights on and off. And we'll talk a little bit more about this in a second. Optimize that patient's environment for it to be calm. And we'll come back to non-pharmacologic approaches. Manage behavioral problems. So think about what's the behavior and why is it happening? Are they agitated because they're in pain? So you have to treat the pain. Rehabilitate the patient in spite of their delirium. So you get them out of bed, get PT to try to walk them. And counsel and support family. There is a paucity of evidence that pharmacologic treatment is going to make a difference. And I'm going to show you a whole group of studies with some evidence. So non-pharmacologic management is your go-to. It's what you should do first, second, third, maybe even 10th. These are the things you should do. And it's really important in doing these that you think about the use of your interdisciplinary team and your families. Coordinate procedures. Don't send that patient for a head CT when there's an hour wait and now they're waiting in the hall. Anybody would get more confused, right? There's been studies using music therapy to decrease agitation, decrease use of sedative hypnotics. Glasses and hearing aids. So one of my colleagues at another institution told me about what they were doing on one unit was they had a donor who gave them some funding to buy reading glasses, like the dollar store readers, to distribute to patients who were having trouble, didn't bring their glasses. And it made a great impact. And this is a low-cost intervention. Hearing aids. They don't bring their hearing aids. They're afraid they're going to be lost. Use handheld amplifiers. If you're not familiar with them, look them up. I know we have them in the hospital. We have them in our outpatient practice, and it makes a big difference in communicating with older adults. You want to continue to encourage independence because otherwise they're going to have functional decline. Use your families. I know that some hospitals don't want families there at night. Ask for permission as long as that family member is not going to make our patient more agitated, right? And use as much that you can do for reorientation and communication. One hospital developed delirium rooms where they placed all the patients who were delirious, well, not, they couldn't do all the patients, were a group of patients with delirium into the same large room, almost like an ICU. And it had increased supervision, environmental factors. So they paid attention to the music, the lights, not waking people up in the middle of the night to do vital signs. And you would think that these delirious patients might feed off each other and make each other more delirious. But in fact, they did better than patients on a general medical floor. What about in an ICU? So I actually found this in a critical care journal where they said no patient in an ICU should have to develop delirium. Well, let's hope that's true. But this is called the A to I bundle of interventions of tools and therapies that will decrease the risks and the triggers as well as managing delirium. And if you work in a critical care setting, this is an article worth looking at. As I mentioned, you definitely want to involve your family members, right? It's scary for family. They don't know what's going on. And this document is from Health and Aging from the American Geriatric Society, which is for the public to educate them on various topics. And this is really a great one. And you can share it with patients. Pharmacologic issues. So the other day I was talking about medication with some of the residents, and they said, yes, but when I get cold at night and the nurses tell me I have to do something to sedate the patient, what am I supposed to do? So antipsychotics and medication should be used only for severe delirium, and if environmental and behavioral therapies have not been practical, they're not available, they haven't worked, and someone is disrupting medically necessary therapies or is a danger to themselves or others. So beware that sometimes we may be triggered to use these drugs because of either our own distress, the caregiver's distress, or staff members, and we may make a decision to prescribe psychotropics when maybe we have other choices. And I'm going to go through some studies with you where they looked at, this is a systematic review, and they looked at typical haloperidol and second-generation antipsychotics versus placebo. No difference in sedation status, delirium duration, hospital length of stay, or mortality. Ooh. So no difference in delirium severity or cognitive functioning for haloperidol versus second-generation antipsychotics, and insufficient or no evidence for antipsychotics versus placebo. But here's something that's interesting. Little evidence demonstrating neurologic harm with the short-term use. So we may not be harming them, but we're not helping them. This study looked at delirium management in adults in hospitals, subacute rehab, and they call it aged care setting because this was from Great Britain. And this was a systematic literature review, and the N was more than 1 million. So the bottom line of it was clinicians continue to use antipsychotics for delirium management, the dose, frequency, and duration of which are often outside evidence-based guidelines. So a few more. Antipsychotic use in critically ill patients. Antipsychotic medications compared with placebo did not increase the number of delirium or coma-free days, did not result in a difference in mortality, mechanical ventilation, ICU, or hospital length of stay. But again, the use of antipsychotics did not result in an increased risk of adverse events. So you're going to use antipsychotics. So before we even talk about dosing, I want you to think about, have you looked, check the EKG, look at whether the patient has QT prolongation, whether it's safe to give this patient. Do they have some other medical issues that you have to think about before you make a choice? So a lot of people are most comfortable with haloperidol. You're going to use tiny doses. Haloperidol is probably the one that has the most rapid onset of action and is the shortest acting. It may be why it's used more frequently. Risperidone also has a short half-life as an atypical and less extrapyramidal side effects than haloperidol. Olanzapine, also known as Zyprexa, is the most anticholinergic and the longest half-life. Quintiapine or Seroquel is your drug of choice for patients with Parkinson's, Lewy body, HIV, dementia with delirium and agitation. So this might be a little bit of help as you're picking medications, but people become comfortable. I'm going to make the point of, don't write these as PRN. Assess the patient. Why do they need them? Have they tried the non-pharmacologic approaches? Is there something else that you need to do? Benzodiazepines, reserve them for alcohol or benzodiazepine withdrawal, as they can worsen delirium. They are used in palliative care in terminal delirium, and that's a whole other talk. Drugs in delirium prevention. So, no, basically, drugs don't work in delirium prevention. So, melatonin and its agonist, Ramulton, it's not in red. It says no, but it's not in red because if someone has sleep-wake problems, sleep-wake cycle problems, this can be beneficial. The alpha-2 agonist, now let's see if I can pronounce it correctly, dexmedetomidine, in the ICU setting, and we'll come to some guidelines related to that, maybe. But any other drugs in delirium prevention? No, except reducing perioperative sedation. Restraints aren't going to reduce your delirium, aren't going to help your patient. They're going to make them more delirious. If you temporarily have to use restraints, please use the least restrictive methods that you can and take them off as soon as possible. Non-pharmacologic delirium prevention. We have to talk about Sharon Inouye again, where she developed this multi-component intervention that targeted 6 delirium risk factors. And you can see those risk factors, and these were really very low-cost interventions, and volunteers were actually trained to do them. It decreased the onset of delirium from 15% to 9% on these units. The number, if people did develop delirium, they went from 161 days to 105 days in delirium. The cost of an intervention was a little more than $300, and dollars saved of delirium prevented, $6,000 or more per patient. The American Geriatric Society has combined with HELP to develop this wonderful online program that you and your hospital and colleagues can look at. It's a comprehensive toolkit that looks at delirium prevention. It has volunteer training and an online community. So I encourage you to look at that. What else is new out there? So some of these are kind of fun when I looked at what's new in 2025. AI-powered headsets. Hopkins researchers are piloting AI headsets that track eye movements and deliver audio messages in the ICU. Interesting. Delirium prevention nurses. So our nurses are really good at assessing delirium, but these doctoral level nurses are really being highly trained to improve delirium recognition, implement prevention beyond the basic tools. This one is a mouthful. Attention and awareness through movement techniques, followed by movement to capacity. Targets cortical dysfunction through sustained sequential touch, cranial nerve stimulation, and muscular movement. It's really interesting. And suvorexant or Belsomra, which has been used for insomnia, is being looked at as well. So these are some new things that are being looked at. I also
Hello, everyone. Sorry for the interruption, and I will be replacing Dr. Fogel in her presentation just to finish this up on delirium. And I really think it's important that we follow APA delirium guidelines because this has been drafted using evidence. And I really, really like these guidelines because they give you different categories and recommendations based on those categories. Extremely important. Dr. Fogel really emphasized this about having structured assessments for delirium. You really need to know what the baseline of the patient is, because if without that baseline, you don't know whether or not this is a change and how significant. You want to do medication review. You want to make sure that you are screening for predisposing factors or maybe contributing factors. Avoid physical restraints, and then then you'll be able to create a person-centered treatment plan. You want to really start, and Dr. Fogel emphasized this, with non-pharmacological strategies for prevention and treatment. Really, really only utilize medications when everything else fails, and low doses. We really avoid antipsychotics to prevent delirium because it actually doesn't, and actually risk of falls. In situations where there may be harm to self or others, it may be your only option, but always start non-pharmacological. Avoid benzodiazepines, and really think about reviewing medications, lowest dose, and being able to titrate off if medications have to be utilized. Think about the transitions of care, whether it be from the ICU to the floor, or being discharged to a subacute rehab. Those are components where patients could be more at risk for delirium. Making sure, as Dr. Fogel mentioned, you want to educate patients, their caregivers. This is very scary for a family member to see their loved one like this. Prevention, non-pharmacological strategies, Dr. Fogel emphasized those. If there's hearing impairment, vision impairment, making sure that this is available. And then it's not recommended to use Haldol, antitypical antipsychotic, statins, ketamine, and then thinking about bright light therapy, and really detecting those subsubdromal delirium. Going back to the patient case, there is a predisposition of delirium. We tried non-pharmacological approaches, which prevented delirium. So delirium is common. It's associated with a significant morbidity and mortality. It's important to screen patients and do a careful medication review, manage delirium with the whole team, really lean into the whole team, and use multi-component non-pharmacological treatment approach, educate family and involve family members, and educate the healthcare team. And the best treatment is prevention. And I'll take one question that was posed about whether or not we should use CAM in a nursing home setting. And yes, it's invalidated in a nursing home setting. ICUs, inpatient, subacute. This is a very easy usable tool. And the more we detect it, the more we'll be able to prevent it. So thank you very much for those questions. If there are any other questions that come for delirium, we'll make sure to post those responses.